Welcome! I'm a respiratory therapist, and you want to know what I do, because if you aren't breathing, you're not doing much of anything else. What's our role in healthcare? For most people, breathing is effortless and occurs spontaneously. Right now, you're breathing and aren't even thinking about it. However, when a disease or injury occurs and normal respiration becomes compromised or ineffective, a respiratory therapist is who you want on your team. Respiratory therapists, RTs, or respiratory care practitioners, are the lung, heart, and airway specialists of the healthcare team. We evaluate and monitor the cardiopulmonary function of our patients and administer therapeutic treatment to maintain heart and lung function. We use our specialized knowledge and training to treat patients ranging from premature infants whose lungs are not developed yet to geriatric patients dealing with chronic respiratory conditions. So where will you find us? The majority of respiratory therapists work in the acute care setting of hospitals large and small. Very small, rural hospitals may run with a staff of 1 to 2 therapists per shift, and larger hospitals may utilize up to 30 or 40 therapists per shift, depending on patient census. Therapists manage patients in the neonatal ICU, where we support preterm infants as their lungs and other body systems develop. In adult critical care, we assist and manage patients with multiple chronic conditions as well as post-operative recuperation. In the cardiac care unit, we monitor and care for patients post-coronary artery bypass graft or valve replacement. In the neuro ICU, we manage vents to optimize intracranial pressures and clear secretions for those patients who may have lost the ability to cough. As traumas roll into the emergency department, RTs are usually found at the head of the bed, managing the patient's airway. We can also be found in the ER, helping a range of patients suffering from emergent conditions such as asthma attacks or respiratory distress. RTs give many breathing treatments on general floors, as well as help manage chronic illnesses such as COPD, asthma, and cystic fibrosis. RTs are integral members of Code Blue and rapid response teams. RTs work in PFT labs, performing diagnostic exams that measure lung volumes and lung function. These exams aid in diagnosing and managing of chronic lung diseases. RTs can also be found in long-term acute care hospitals, caring for those with tracheostomies who may need to be on ventilators for prolonged periods of time. Pulmonary rehab is where we work with chronic lung disease patients to decrease shortness of breath, increase exercise endurance, and maintain or improve lung function. Respiratory therapists also work in sleep labs, outpatient clinics, doctor's offices, and home health. The Commission on Accreditation for Respiratory Care is the accrediting body responsible for assuring high-quality education to prepare competent respiratory therapists for practice, education, research, and service. Respiratory therapists can take board exams after successfully completing a degree from an accredited program. As of now, entry level for an RT can be an associate level degree. There are 208 associate level programs in the United States. RTs can also graduate with a bachelor's degree from one of the 61 bachelor's programs or master's degree from one of the 12 master's programs. There is one doctorate degree available through Rush University in Chicago, Illinois. The National Board for Respiratory Care is a nonprofit organization responsible for the awarding and maintenance of credentials for respiratory therapists. After graduation, potential therapists sit for the therapist multiple choice exam, with the possibility of scoring within a range to be considered certified or registered. Once scoring at registry level, the potential therapist is allowed to take the clinical simulations exam. Successful completion of the clinical sims fulfills the full designation of Registered Respiratory Therapist, or RRT. The NBRC offers multiple specialty board exams to be taken after a therapist is registered. These include adult critical care, neonatal pediatric, pulmonary functions, asthma educator, and sleep disorders. So where are we going? Respiratory therapy is a young profession, with on-the-job training only beginning in the 1940s. and formal education classes starting in the 1950s. The American Society for Respiratory Care recently released a position statement on respiratory therapist education, calling for entry to practice as a respiratory therapist to be at least a bachelor's degree level. All new RT programs will be accredited only if they offer a bachelor's degree or higher. COARC has also recently developed standards for a mid-level practitioner known as an advanced practice respiratory therapist. After obtaining the RRT credential, therapists would complete graduate level education that allows the APRT to provide advanced, evidence-based diagnostic and therapeutic procedures and disease management as part of a physician-led team. This is in the very beginning stages of development, and state medical licensing boards will need to evaluate, write new licensing laws, and adjust accordingly. So what do we work with? You will most definitely see us with a stethoscope and a pulse ox. We rarely assess a patient or give a treatment without using one or both of these tools. We want to hear the lungs and measure oxygenation. A pulse ox tells us the percent oxygenated hemoglobin in the blood. For true oxygenation and ventilation status, we will need to get an arterial blood gas, usually taken from the radial artery. ABGs are ordered on patients whose ability to oxygenate or ventilate is questionable. ABGs are also ordered for patients on life support or ventilators, which is another piece of equipment that we work with. So RTs can assess and adjust settings to be therapeutic and to maintain acid-base balance. With a ventilator, RTs can completely control a patient's respiratory pattern, or we can support patients' efforts to breathe. Our goal, once a patient has been put on a ventilator, is to provide the support and care the patient needs in order to extubate, so that they can breathe on their own. More things that we work with. The incentive spirometer is one of the most simple but effective tools an RT uses. An incentive spirometer prevents atelectasis, or lung collapse, by forcing patients to take long, slow, and deep breaths in. The majority of patients in the hospital are ordered an IS. It's very important for post-operative patients or patients who are bedridden and not moving around much. RTs administer medications for the airways and lungs, mostly through the modality of a nebulizer. Nebulized medications reach far into the lungs to open up airways, treat infection, break up mucus, and calm inflammation. Medications also come in metered dose inhalers, or puffers, as many of our patients call them. MDIs should be given with spacers to optimize medication deposition. RTs perform bronchial hygiene on a range of patients who need help moving secretions up and out of the airway. There are multiple types of ways to accomplish bronchial hygiene, but one of the most common is to perform a series of claps on a patient's thorax while the patient is positioned in such a way to encourage secretions to drain into the main airways. Cystic fibrosis patients do this type of treatment 3 times a day. Who and what do we treat? Everyone. We treat all types of patients, from a 24-week-old neonate to a 104-year-old geriatric, and everyone in between. If a patient is having trouble breathing, then they are seeing a respiratory therapist during their hospital stay. Some of what we treat are COPD, asthma, traumas, surgical complications, prematurity, cystic fibrosis patients, heart patients, sleep apnea, and neuro patients. So how do we treat this case study? The patient, a 42-year-old white female presenting with stroke signs and symptoms, respiratory therapists would care for her in the following ways. In the ER, we would administer oxygen via nasal cannula and ensure airway safety. Once moved to the ICU, we would do ventilator management and get ABGs to assess readiness to wean and extubate. On the floors, the patient would receive nebulized medicines and bronchial hygiene via PEP therapy. And once out of the hospital, during rehab, the patient would get smoking cessation education and support, as well as oxygen delivery. This was a brief overview of what a respiratory therapist does. Thank you for your attention.